28-year-old male graduate student, presents to his physician after 4 weeks of headache that are affecting his academic performance. Over-the-counter medications do not seem to help. He also mentions that he has to raise his head each time he looks at the board to take note. His blood pressure is 125/75, pulse 86, respirations 13, temperature 36.8 degrees Celsius. Ophthalmic examination reveals upward gaze palsy, convergence retraction nystagmus and papillary edema. CT scan of the head reveals 1.5 times 1.2 centimeter heterogeneous mass in the epithalamus with dilated lateral and third ventricle. Which other finding is most likely to be associated with this patient's condition? Options: medial strabismus, sensory neural hearing loss, pseudo-Argyll-Robertson pupil, eyes down and out, conducting hearing loss. And over here, they already told you that there is a mass in the epithalamus. Epithalamus is where your pineal gland is, causing dilated lateral and third ventricle. They are already telling you that there is obstruction of the aqueduct of Sylvius, leading to the same features like Parinaud syndrome and everything. But what are the feature that you will see is what they are asking, and the answer is pseudo-Argyll-Robertson pupil. Right? So pseudo-Argyll-Robertsonian pupil is because there is damage to the pretectal nuclei in the midbrain. We are not sure what that nuclei basically does, but it's involved in the constriction. If you remember your pupillary light reflex, pretectal nuclei is part of it. And damage to that is what is causing the pseudo-Argyll-Robertsonian pupil. Don't confuse this with the Argyll-Robertsonian pupil that you see it in syphilis. It's going to behave in the same way, but anything outside, or you can say any non-syphilitic kind of the same reaction, it's called pseudo-Argyll-Robertsonian. Again, the treatment and everything, diagnosis is going to be the same. You can do CT and MRI as they did in this patient to look for the tumor, to look at the dilated ventricles and the obstruction. You can do surgery and chemo and radiation depending on what cell is causing the tumor. Okay, so that's why the answer is pseudo-Argyll-Robertsonian pupil, just because it's the area is a pretectum. The whole pineal gland and everything is the tectum, which is the dorsal midbrain, right? Tegmentum is ventral midbrain, so don't get confused between the terms. And pretectum is in the pretectal nucleus is in the dorsal midbrain, and that's why patients are going to have Argyll-Robertson. Medial strabismus, as I mentioned before, it's going to be the medial deviation of the eyes, and that is because your abducens nerve is injured. It's not injured in this case, so you will not see that. Sensory neural hearing loss, that happens, as I mentioned, I think inferior collicular I mentioned it was regarding the auditory canal. So if that is involved, then you can have sensory neural hearing loss. But it's very rarely involved in a pineloma, so not an issue over here. Eyes down and out, as I mentioned before, it's going to be oculomotor nerve palsy, not involved in this patient again, right? So you will not see that. Conducting hearing loss is going to be your either external auditory canal, something wrong with your eardrum, or even otosclerosis can also cause that. If all of that is okay, you will not be having conducting hearing loss. The test you can do is like Venian, the Weber and the Rinne's test that you can do, and to diagnose whether it's conducting or sensory neural hearing loss. But not involved in this patient, so again, not a question over here. You can easily rule that option out.
Thanks for watching. Please give a thumbs up and subscribe for more.